Hello everyone, now we continue with our discussion of the nephrology. So as usual, I'm going to summarize these complex case scenarios in 1 to 2 lines that are the most high yield that give you the answer. Okay, so this is what we do. So you see a patient who's 40-year-old, came in, evaluation for edema. Okay, so you examine the lower extremities, there is 3 plus edema. Okay, pitting edema. Okay, so what, and then they will ask you what's the diagnosis. So you do your analysis, there's a 3 plus protein. So there is edema and there's a protein. This means there is a nephrotic syndrome. So what's your diagnosis for this patient? It's called minimal change disease. Okay, this case. Now we go to the now this brings us to the discussion of minimal change disease. When do you see that minimal change disease? Someone who aged more than 45, sudden onset of symptoms, there's hypertension in 43% of cases, and you have nephrotic range proteinuria more than 3 grams per day. You see serum albumin less than 2.2, and total cholesterol more than 420, and you see acute kidney injury in 18% of the cases. Okay, so this is minimal change disease. That's kind of the most high yield information that you need to know about it. Okay, now we have another case. Let's say you get a patient who's 67, came in with fatigue and abdominal discomfort and cough, edema, there is systolic murmur, and then you check the total protein, it's pretty high, total protein is high. There is bilateral pleural effusion. Cardiomegaly chest x-ray shows cardiomegaly and bilateral pleural effusion. So what does that tell you? What is the diagnosis? Like if there is high protein, okay, and fatigue, abdominal discomfort, cardiomegaly, this could be most likely the diagnosis is multiple myeloma. Okay, multiple myeloma. What other features of multiple myeloma can present with bone pain, fatigue, weakness, and weight loss? Can cause anemia, elevated creatine, hypercalcemia, and it cause monoclonal protein in serum or urine protein electrophoresis. That's how you find out about it. And you can do urine dipstick protein, quantitative protein analysis, discordant. Okay, so you will see urine dipstick protein and the quantitative protein will be different values. Why? Because you have light chain protein in the urine. And the gold standard, when you do bone marrow biopsy, you see more than 10% plasma cell. On imaging, you see lytic lesion on CT scan, PET scan and CT scan. You see on MRI or X-ray, lytic lesion. Could be complicated to osteoporosis, fracture, and pathologic fracture, multiple myeloma. I've had patients like that in real life, and this requires multidisciplinary collaborative treatment. Okay. So now we see this case. You see 44-year-old came in with shortness of breath that began when he woke up today. Okay. So shortness of breath, and the patient was recently diagnosed with membranous nephropathy. Okay, patient was diagnosed with membranous nephropathy, and the question is, what are the complications for that? Okay, there's urine protein in the urine. Okay, so when you're peeing a lot of protein, one of those is antithrombin. So this increased risk for thrombosis, especially renal vein thrombosis. This is important and high yield to know. Okay, and nephrotic syndrome. Nephrotic syndrome, usually 24-hour urine protein more than 3.5 gram. You're peeing 3.5 gram of protein every day. There's edema, there's hypoalbuminemia, hyperlipidemia, and lipiduria. Okay. Causes could be minimal change disease, focal segmental glomerulonephritis if there's HIV patient, membranous nephropathy, amyloidosis, diabetes can cause that. What are the complications for that? Complication, you can have protein malnutrition, you can have hypovolemia, renal failure, thromboembolism, like in this case. You can have infection, especially pneumococcal infection. and you can have proximal tubular dysfunction causing vitamin D deficiency, and you'll end up causing a weak bone and fracture, all of that. Now the question here, what's GFR is the worst? Which one, creatine going from 4 to 8 or 0.8 to 1? So GFR question. So creatine going from 0.8 to 1.2 is a lot worse from creatine going from 4 to 8. So that's what the idea they want you to know from this question. Because early AKI, there's a small change in creatine, but a large change in GFR. Advanced chronic kidney disease, there's large change in creatine, but very small change in glomerular filtration rate. Alright. Now, we have this patient who was hospitalized for GI bleed, like 66-year-old man, had GI bleed, so obviously you give him PPI, omeprazole, if they have GI bleed, to stop, like to decrease the GI bleed. And then, so you do regular labs, like a few days later that you see the kidney worsen, the kidney causes, creatine causes 2.5, and you do urinalysis. In urinalysis you see red blood cells 20 to 30 and white BC casts, and they ask you what to do, what could be causing that. This can be caused by omeprazole. Omeprazole can cause acute interstitial nephritis. This is very common and you need to be aware of. So what you do, you discontinue omeprazole. Okay. Other causes could be NSAID, antibiotics, could be rheumatologic disease like Sjogren's syndrome, sarcoidosis, SLE, Legionella, tuberculosis, CMV can cause that. The way it presents, there's a new medication exposure and cause kidney injury, arthralgia, fever, eosinophilia can happen as well. The way you diagnose it, you see white BC and white BC cast on urinalysis and proteinuria, and you can have peripheral eosinophilia and urine eosinophil as well. You can do renal biopsy, shows tubular interstitial inflammation and edema. And the management, you discontinue the drug or treat underlying condition, do systemic steroid and supportive hemodialysis if needed. Alright, now we see that if there is a case, you see somebody with right flank pain in a 55-year-old. Okay, so you found there's a stone, uric acid stone. Okay, there's uric acid stone. So beside high fluid intake, what would you do? What's the best next step you recommend? You give them potassium citrate, would be pretty helpful. Okay, so for uric acid stone can happen from gout, myeloproliferative disorder, chronic diarrhea, metabolic syndrome. Treatment is urinary alkalization and allopurinol. Calcium stone can cause from hypercalciuria, hyperparathyroidism, hyperoxaluria like malabsorption or low calcium diet, hypocitraturia, there is distal renal tubular acidosis, and or high sodium, high protein, high oxalate diet, low calcium can trigger calcium stone. How do you decrease intervention to prevent that? Reduce calcium, so reduce sodium, animal protein and oxalate intake, increase potassium intake, and adequate calcium intake, not too much, not too little, and you give thiazide diuretics, helpful with that as well. How about magnesium stone? Struvite it's called. Usually come from Klebsiella proteus, so you don't remove the stone, antibiotics. All other types of stone, you just increase the fluid intake. It could be triggered by dehydration. Okay, so now if you have somebody who's 44, came in with recurrent kidney stones, okay? Someone's have recurrent kidney stones. What's recommendations for them? Calcium oxide stone. So you do decrease sodium in diet. Okay, this is the recommendations for calcium oxide stone as well. Dietary sodium restriction. So for the calcium oxalate stone, to prevent recurrence, you want to increase fluid, decrease sodium, and increase citrate, potassium, and animal protein. Adequate calcium intake, like 1200 milligram per day, and decrease oxalate from spinach. And you give thyroid diuretics, potassium citrate could be helpful too. So these are intervention to prevent calcium stone. Okay. Now you have a 60-year-old, urinary symptoms and rubbery prostate. What's best next step? You do refer to urologist. Okay, this is kind of the idea to do. Okay, so what do you do? Prostate cancer screening. This is important. If normal digital rectal exam and PSA less than 3, just do routine follow-up. If someone have normal digital rectal exam and the prostate is like 3 to 7, you repeat prostate in a few weeks later. If it's lower, less than 3, then just routine follow-up, nothing to worry. If it's increased more than 3, you treat it as same as if there's abnormal digital rectal exam or PSA more than 7. You refer to urologist. You can do truss-guided prostate biopsy, transurethral, ultrasound-guided prostate biopsy without further testing. Okay, so you need that. Okay. Now you have somebody who had 55 with fever, chills, tender prostate. And best next step, what do you want to do? This one, you want to give levofloxacin. So this is a prostatitis. Okay, acute prostatitis, you give Bactrim or levofloxacin. Usually causes fever, pelvic pain, cloudy urine, pyuria, tender prostate, E. coli positive. Chronic prostatitis usually have dysuria, urinary frequency increase, there's no fever or chills, and you have recurrent urinary tract infection as well. The treatment is just fluoroquine alone for this patient if they have chronic prostatitis. Now, so if you see patient came in like 44, came in with ultrasound, shows like 2.4 centimeter renal cyst with smooth walls, anechoic, strong posterior enhancement. What do you do? Like round walls. What's best next step? It's just observation. You know, it doesn't have malignant features. You know, so for renal cyst, this is what you would do. There's round, thin, smooth, regular border, no calcification, no septi. There's posterior enhancement on ultrasound, no contrast enhancement on CT. These are just reassured, very low risk for pregnancy, less than 1%. But if there is a few septi, few calcification, no contrast enhancement on CT, this depends, less than 3%. You can just do follow-up 6 to 12 months. But if there's thick, irregular wall, multiple thick septi, enhancement on CT, this you need surgical excision of mass or nephrectomy because there's 90% risk of malignancy. Okay, this is renal stone. Okay, we talked about renal stone, we talked about prostatitis management, urologist if there is large prostate, decrease sodium, and give potassium for stone. Discontinue omeprazole if there is interstitial nephritis. Talked about creatine, GFR relation, renal vein thrombosis and membranous. Talked about multiple myeloma and minimal change disease, and that summarizes our discussion for this section. Thank you for listening.